Initiative. We're so excited to share with you the results of HIE's 2019 Health Information Exchange Survey. Before we get started, let's review today's agenda, some housekeeping, and some background information on HIE. I'll start off by giving you some background of the survey and a brief overview of the report's key findings, and then I'll turn it over to Dr. Chris Hobson, Chief Medical Officer at Orion Health, who's joining us to moderate a fabulous panel of industry experts for a rich discussion on the results. Thanks so much to Joe O'Hara, Director of Clinical Innovation, Horizon Blue Cross Blue Shield of New Jersey, Katie Senze, Director of Client Operations and Programs at Health InfoNet in Maine, and Mike Sims, Chief Financial Officer at the Delaware Health Information Network, for joining us. We'll then have Claudia Ellison, HIE's Director of Programs and Services, finish the hour off with an audience Q&A. Next slide. Just a little housekeeping. All participants are muted, but we still want to hear from you. So if you'd like to ask the speakers a question to be answered during the Q&A session, you can use the Q&A box that's at the bottom of your screen. We'll do our best to get through as many questions as we can. And if you need any help or if you have any non-speaker questions, you can use the chat box, which is the little speech bubble found at the bottom of your screen. Finally, the slides are available now in our Resource Center. A link to the recording will be added to the same location this afternoon. Next slide. So a quick couple points about eHealth Initiative. We're all about convening executives from across stakeholder groups, bringing together the key players to focus on the critical issues that need to be dealt with to transform healthcare. Next slide. We're identifying and defining problems, convening, educating, and influencing key players, and promoting best practices and solutions. Next slide. Our members come from all different groups, including payers, providers, vendors, researchers, consultants, patient advocacy groups, and more. If you're interested in being at the table and helping to transform healthcare, I strongly encourage you to get involved with us. Next slide. Right now, our biggest focus is on 4 key areas. We're doing various initiatives around value-based care, interoperability, privacy and security, and analytics. Next slide. I'd like to remind everyone about the HIE Resource Center that's located on our website. As a nonprofit, we produce a ton of best practices, reports, surveys, interviews. We also want you to share what you and your organizations are working on. You can click the green button at the top of the resource page to contribute your own resources. Next slide. And our newest report, which is really what brings us all here today, is now available for download on our Resource Center. You can find it on the link here, or simply visit our homepage, ehiedc.org, where it is being featured and easily accessible. Next slide. And I'd like to thank Orion Health. We're a small nonprofit, and we could not do this important work without the generous support of organizations like Orion Health. So let's get started. Next slide, please. So first, I'll tell you a little about the survey. Next slide. Since 2004, HIE has conducted a comprehensive survey assessing the current state of data exchange within the United States. Over the years, the survey has grown from one that examined the beginning stages of HIE into one that gives insight into the overall progress and growth of HIE throughout the country. Next slide. This year, in response to healthcare's recent rapid evolution, especially with the emergence of new technology and payment models, we wanted to ask health information exchanges, or HIEs, what they're focusing on in the next 2 years and what's driving them to do so. We also wanted to know their biggest challenges in adopting new services, integrating clinical and claims data, and exchanging different data types. Next slide. The electronic survey was open February through April of this year. Invitations to take the survey were sent to an email list of individuals identified as being in a leadership position at an HIE in the US or US territory. Anyone responding that they did not work at an HIE were disqualified. The survey consisted of 20 multiple choice questions, and the results were discussed during follow-up interviews with 3 organizations that participated in the survey. While responses were reviewed by HIE staff for reasonableness, this survey should be considered a non-scientific snapshot of industry perspectives and the state of the field. Next slide. And next slide. After review, a total of 53 responses from unique US-based HIEs from 35 states were included in the results. The majority of respondents identified themselves as being regional or community HIE. And if you're interested to see which HIEs participated, a list can be found at the end of the report. Next slide. The first thing identified in the report are the respondents' top business drivers and priorities for the next 2 years. Next slide. Over the years, different market and policy elements have helped drive health information exchange. In 2019, we found that respondents' top business drivers are managing risk and delivery on value-based contracts, easier integration through APIs, and providing clear value to end users. Next slide. Unsurprisingly, respondents are prioritizing interoperability, value-based care, and integrating workflows in the next 2 years. Next slide. So I'm looking at the top priorities and business drivers and seeing that 92% of the respondents agree that value-based care trends influence their decisions about technology adoption. We're finding that value-based care is a major driver. Next slide. Another interesting point we found in looking at the priorities was that only a third of respondents in the 2019 survey chose long-term sustainability and financial viability as a top priority. If you go back to when HIE first started doing these surveys, the story is a little different. In HIE's 2005 survey on HIE initiatives and organizations, 84% of HIEs considered developing a sustainable business model a very difficult or moderately difficult challenge. We can't say for sure why this is, but in our work, we're seeing that HIEs are establishing themselves in demonstrating value to their communities. There has also been a decrease in the number of HIEs in the US over the last 2 decades due to changing economic conditions, consolidations, market forces. The 2005 report is in our resource center. There's a link to it in this report if you'd like to read more. Next slide. And next slide. When HIEs first came into existence, very few payers participated in data exchange. But now, more payers are actively exchanging data with HIEs. And as a result, HIEs that work with a number of payers help exchange data for the millions of members each payer represents. The survey asked respondents to indicate how many payers participate in their exchange. 15% said they don't have any payers, a third have 1 to 3, and the other half have 4 or more payers in their exchange. But asking the number of payers doesn't necessarily correlate with how much claims data an HIE is exchanging. Next slide. So we decided to get a feel for the amount of claims data these HIEs would be managing. And we were curious whether HIEs managing large amounts of data, claims data, and those with little or no claims data would report varying abilities and challenges. Throughout the report and on the webinar, when we say a respondent has however million members, we're talking about how many people the HIEs have access to claims data for. Like this example on the slide, this HIE has 3 payers with varying numbers of members. And overall, that HIE has access to claims data for more than 3 million members. Next slide. So here you can see most of the respondents have 3 million or less members in their HIE, and about a quarter of them have 3 million or more. And just to note, 10 people said they weren't sure, so they are not included in any of the breakdowns. Next slide. And while claims information already held by the payer may provide some data for activities that support value-based care, access to both claims and clinical information helps payers do so much. So a key finding we found on the survey is that a majority of respondents have seen a significant or very significant increase in demand from payers for more access to clinical data. And we wanted to know, do the HIEs then have the ability to integrate clinical and claims data? Next slide. And we saw that a majority of respondents overall do have the capability to integrate clinical and claims data. And in diving deeper, HIEs with over 3 million members are even more likely to have this capability than those with 3 million members or less. Next slide. And HIEs are faced with numerous challenges related to resources, sources of data, and technology. Survey results suggest that for respondents with at least one payer participating in their exchange, thus exchanging at least some claims information, the most significant challenges in managing claims and clinical data are data quality issues, cost of technology, and availability of qualified staff. Next slide. So moving on, we looked at which technologies HIEs have already adopted, which they're likely to adopt in the next 2 years, and what their biggest challenges are in doing so. Next slide. And survey says, respondents have already adopted surveys such as provider alerts and HIE to HIE exchange, while very few HIEs have adopted services such as medication reconciliation and remote patient monitoring. Next slide. And when we look at what's coming down the road, 3/4 of respondents say that their technology budgets are likely to increase in the next 2 years. Next slide. So what's coming next? Some technologies, such as care coordination tools, are likely or very likely to be adopted by respondents in the next 2 years, while others, like remote patient monitoring, are not likely or not very likely. Next slide. And in doing a deep dive between those with 3 million or less members and those with more than 3 million members, we saw a few differences, though nothing too big. For a deeper dive into care coordination, all-payer claims database, and remote patient monitoring, be sure to check out the report. Next slide. And while technology budgets are likely to increase, there are still significant challenges to adopting new services, such as cost, competing priorities, and enhanced utilization and optimization of the solution. Next slide. Next slide. So we wanted to see what the challenges are in exchanging data. Some data types are typical for HIEs to exchange, but as the healthcare industry aims to gain a more accurate picture of a patient, they're seeking access to a wider range of data types, and some are proving more difficult to exchange than others. The two most challenging data types, both chosen by over half of respondents, were social determinants of health data and behavioral health data. Next slide. And we also did a deep dive based on number of members for difficulties in exchanging data types. Some types were reported as challenging to exchange at similar rates across groups. For example, about half said that social determinants of health data is difficult to exchange, and only 15% reported radiology images as difficult, which gives HIE a sign of progress in this area. Other types differed across groups. Respondents with more members indicated a higher percentage of difficulty in exchanging medication-filled data and quality reporting data, while respondents with less members reported a higher percentage of difficulty in exchanging behavioral health data. If you'd like to see a more detailed analysis, be sure to take a look at the report. Next slide. And lastly, everybody's talking TEFCA, and we asked respondents how significant they think TEFCA's impact will be on interoperability. found that almost 2/3 said it would be significant or very significant. Next slide. And I'd now like to turn it over to Dr. Chris Hobson, Chief Medical Officer at Orion Health, who will be moderating a panel of fantastic speakers who have graciously joined us to give us their insights on the results.
Thank you so much, Kaylee. Thank you again to our three panelists. Before we get started on the discussion, it would be good if I could ask each of our panelists, give them the opportunity to introduce yourselves and give us a little background on your organization. We'll go in alphabetical order, so we'll start with Joe.
So I'm the Director of Innovations for Healthcare Management with a single state Blue Cross Blue Shield plan, Horizon Blue Cross Blue Shield of New Jersey. And we have a private data exchange platform with records for over 6 million individuals on it, 4 years worth of history. It has both payer and provider data. It has filled pharmacy for about half of the individuals on the platform, full lab values coming from the national lab companies. And then it's got 7 large health system partners in the state of New Jersey who are contributing data today, and a number of viewers in the marketplace who are not necessarily integrated, but can, through our provider portal, access the platform.
Very good, thank you. Katie?
Hi everyone, my name is Katie Sensei. I'm the Director of Client Operations and Programs for Health InfoNet, Maine Statewide Health Information Exchange. And I've been working with Health InfoNet for a little over 6 years now, and look forward to talking about all of the questions folks have written in about and some specific topics that seem like were themes over the survey results.
Thank you, Katie. And Mike?
And this is Michael Sims. I am the CFO with the Delaware Health Information Network, the HIE in the state of Delaware. I'm pleased to announce we've just been live for just over 12 years. We started back on May 1st, 2007. We deliver around 15 million results to our various customers throughout the year. And we also have clinical information that we deliver that way. In addition, we went live with our APCD back in October of last year, and so we're real excited, and we're in the middle of starting to combine the clinical and claims information. So that's something that we're looking forward to doing in the future.
Very good, thank you. So since the first part of the survey, we're looking at payer-provider integration and some of those issues, perhaps Joe, as payer of the group, would you like to get us started, some background of payer perspective, why are payers interested in HIEs, and are you and other payers, consistent with the survey, seeking more access to clinical data, and if so, for what purposes?
That's a lot of questions, Chris.
Oh, wow, okay. I'm sure you can handle it. I'm sure you can handle it.
Origin-wise, as a payer, we have been involved in what we would call the value-based marketplace for 7 or 8 years. So that's ACOs, episodes of care, patient-centered medical home, and we have hundreds of partners working with us in the state of New Jersey in that space. And right from the beginning, the message we heard was, we need access to data. If you're expecting us to pursue better outcomes with your members, their patients, we need access to better data, more comprehensive data. We need to understand what's happening when the patients are referred out to specialty. We need discharge reports coming from hospital, et cetera. And so initially we provided that usually via flat file or even Excel spreadsheets to our provider partners, but very quickly recognized that we, one, wanted a bi-directional exchange of data, and 2, we needed to do something that was near real time, right? So flat files and other reporting type transactions tended to be monthly and not current enough for a lot of the cases that we wanted to pursue with our provider partners. And we wanted, we needed data for them that Horizon didn't necessarily have. So we were looking for records like CCDA, ORU, PPR, VXU coming out of EMR systems to help complement the encounter-based data that we had. And I guess the last part of your question, Chris, is what are payers doing with the data? The first thing we're doing is sharing, right? So that our goal is a comprehensive patient record to facilitate patient encounters, no matter where the encounter is happening. So sharing is the primary goal. After that, the next piece is patient targeting, right? If we can build a more comprehensive database to identify patients for special programs, and to kind of give you an idea, a payer like Horizon might be running anywhere from 30 to 40 different programs that are differentiated by either condition, disease type, disease stage, location, employer. So we run all sorts of programs for our employer clients, for just different disease state members. And we need to identify those patients in the most comprehensive way possible, right? So not just understanding that they have diabetes, but understanding the stages of disease, where the patient is with regards to symptoms, other comorbid conditions. So the better we can do that, the better we can assist either our treating physicians or Horizon's care managers in addressing those patient needs. So that would be, that's kind of the number two. And then the number three reason is to support quality measurement initiatives that generally are coming from organizations like CMS, so STARS for Medicare Advantage, HIEs, so that would be for commercial populations. Then we have measurement programs for our Medicaid program and for our ACA membership. I'll stop there.
No, that's great. That's a great insight. So really, in summary, you're really looking to providers to move to value-based care models, then they needed to have data, and so you took it on yourselves to help significantly find data and make it available to them. So that's fantastic. So turning to Mike, as a more of a provider-based HIE, at least initially, and from the survey, we see that majority of HIEs are interested in or can currently integrate clinical and claims data. Can you say from your perspective that the ability to integrate claims and clinical, what are the best uses? What are you doing with it from your experience? And why?
So, consistent with what Joe said a little bit earlier, the biggest benefit that we're seeing is to provide a more complete historical record of the patient. We currently have HL7, ORU, clinical information from all the hospitals, reference labs, urgent care facilities, and about 30% of the practices in the state. And so one of the things that we set up with about, I guess, around 11 of our major EMRs is that, after every patient visit, after every patient encounter, in the doctor's office, they will automatically send us a CCD document, and that will sit and be added to our CHR, our clinical health record, our community health record. But that still leaves us about 70% of the practices and the urgent care facilities, and so we still have a bunch of holes in the longitudinal record for all those instances. And so getting that claims information and pulling the ICD codes and translating them, to common sense language, that a doctor can easily see what happened in those instances. That's just going to make our service and our product, that much more valuable.
Right. So absolutely. So again, if people are looking to fully understand their population, then they need the complete data. Just a small point though, so a number of respondents in the survey cited the availability of claims data as a significant challenge. And I wondered, perhaps Joe or Mike, do you think that it's just the technical difficulty of accessing and working, exchanging with claims data, or do you think that maybe there's some other factors going on there? Maybe start with Joe.
So Chris, could you restate the question a little bit?
Yes. Yes. So
I guess
in the survey,
from a payer standpoint, our challenge hasn't been the payer data, right?
Right.
It's been actually the provider data. And
okay.
that's understandable, right? We're comfortable in our own space, but not necessarily comfortable in the new space.
Exactly. So maybe just give us a quick summary of from your perspective with the provider data, the challenges.
So I guess I think some of the things we've seen as we're working with different provider partners is they think of the data in two different ways. And so, so in some ways the data supports reimbursement, and that data tends to be much cleaner. They do a better job curating that data set. And the other data which supports care, right? So the EMR data that's supporting that the caregivers are viewing, while not always comprehensive, in general, I think the point of view is they can see everything they need to see. So even though some data may be in the wrong fields, or some data is entered in a comments field as opposed to in the field for the data, the user is quite comfortable in finding that data. They have customs within each organization. They know where certain data elements are. But when that data is being exported, that's when we as a user run into challenges, because there isn't, what's the right word? Uniformity would even be too much. There isn't a common across organization in terms of the type of data that's available, how it's reported, how it's stored, and how it's output.
Got it. That makes a lot of sense. Mike, did you want to make some comments in terms of your ability to handle claims data? Would that echo what Joe was saying about the exports? Yeah.
This I'd say analogous to what Joe was saying, but juxtaposed, so to speak. Claims data, it's relatively new territory for us. So I think in the inverse, we're in the same boat that Joe's in. In the meantime, though, we have hired some people who have lots of experience with payer information. And so, ultimately, what we want to do with the information, our end goal, when we decide to stand up the APCD, is to actually, marry the claims and clinical information, so that ultimately, for the state, for people like Medicaid, and then maybe ultimately for Medicare and other, national payers, is to be able to say, all right, if a person goes into hospital, A for a hip replacement that costs $100,000. But if the person gets readmitted 30% of the time, then that's going to cost, I don't know, another $60,000 for each one of those instances. Whereas the person, if they go to hospital B and it costs $110,000, but if the person only gets readmitted 5% of the time, then that tells us something. And so ultimately, that's what we want to see, is to really see which providers are providing really the best value. Not just maybe results, but when you combine the financial information along with that clinical information that we already have, to really see which providers are doing the best job. But ultimately, for those providers who maybe aren't, to then contact them and understand lessons learned, so that ultimately all patients can benefit.
Oh, that's fantastic. And I just realized, so Katie, it'd be great to hear your perspective from Maine Health InfoNet in terms of value-based care, claims data and clinical data and your experiences.
Sure. I'm happy to share what we're seeing in Maine and learning from other states as well. In Maine today, Health InfoNet does have a back and forth relationship related to the HIE clinical data and Maine's Medicaid program, which is called Maine Care. We've been doing this for a number of years, receiving Medicaid claims, integrating that in different ways with the clinical data sets we have. We integrate claims data to close lots of data gaps, as the other folks have talked about. In particular, medication and pharmacy information been very important and helpful to closing gaps in medication history, just due to the different claims adjudication vendors that are used between commercial pharmacies, et cetera. In the other way, it's been very helpful in filling data gaps that are really important for having strong predictive analytics risk score models, particularly in the area of utilization analytics when you're looking at predicting a patient's likelihood of a 30-day hospital readmission or a return visit to the emergency room, that kind of thing. And I would say the third thing that's important about what we do with Medicaid in Maine is providing real-time, data views and reporting tools that they can download and export into their own work environment from a care management perspective. And I think this tends to be the trend across all payers, is to leverage real-time clinical data. Mostly people are focused on ADTs related to the emergency room and hospitals. It's really acute care utilization and notification around which of their members are receiving care now in an acute care setting, and then performing different care management workflows based on that information. A lot of folks are focused on appropriate emergency room utilization versus quote unquote inappropriate, and having real-time chief complaint information and then final diagnosis and coding information to help map and understand appropriate use of the emergency room has really been a big focus of all of the value-based purchasing programs, whether it's Maine Care or commercial or otherwise, as well as all of the ACO arrangements that exist in Maine. Same type of thing, using ADT notifications and analytics to really look at daily acute care census to understand who's going for what reason, and then using that information for care management referrals and follow-up home visits and things of that nature. We are not receiving claims data today from commercial payers or Medicare, and there's probably lots of complex reasons for that. I think that kind of the quote-unquote easy place to start is looking at Medicaid and supporting the state around those efforts. I think that's something everyone is very aligned around. I think there's still there's more questions than answers in Maine around the, how we can work together from an HIE's perspective. We really are a neutral party in Maine, where we operate on behalf of our participants, which are the healthcare providers who are submitting data to Health InfoNet. So that conversation is evolving, and I think is going to take some more time. And we will, continue to help facilitate those conversations as the participants come forward with use cases around that. And we also support public health reporting in Maine. Any mandated public health reporting, our participants support that to support syndromic surveillance, electronic lab reporting, and other mandated workflows. But that is really the scope of our work with payers in Maine.
That's fantastic. So just to wrap that piece of the discussion up, it sounds like with sophisticated and high quality data from both clinical and claims, it is possible to move forward in the areas of value-based care. And then there's a level below that where it sounds like a lot of the time it's coming around to quality measures and then care management and care coordination and some of those topics, and then very specific use cases which kind of drive progress forward. I really appreciate everybody's contributions there. So I'd just like to move on a little bit and discuss, so in the survey, two types of data, the social determinants of health data and behavioral health data, were found to be the most challenging, listed by participants as difficult to exchange. So I wondered, perhaps if we start with Katie again, why is it difficult? Do you have difficulty with that type of data? And perhaps just throw in a little more tricky one, is that data worth the effort? So perhaps give us your experiences, behavioral data, social determinants data, and lessons learned, and is it worth the effort?
Sure. I'll try to touch on that a little bit in each area.
Yeah.
I think social determinants of health data means different things to every community, and I think it's absolutely worth it. We have to find ways to move forward in this area as it relates to what's important in your local community, state departments, et cetera. So in Maine, we recently joined participating in the Siren Gravity Project. So if folks want to look up Siren Gravity Project and learn more about what that is, I have a website and there's people you can follow up with. But that group is really the national effort right now, looking at how can we really hone in on creating data standards for HL7, using HL7 for 3 social determinants areas: housing, food insecurity, and transportation. Those 3 areas have also been the focus of data collection in Maine. We started with transportation data based out of claims data collection processes that our Department of Health and Human Services set up with the entities that provide non-emergent transportation services. Other projects that I know we're working on CMS with, and I know many other communities are working on, is housing, in particular with the HUD-required homeless management information systems. You see a lot of integration with HIEs in that space because it's standardized aggregated data in some senses. And so we are looking, we're in process around that in Maine as well. And then obviously Medicaid claims. I think that what we are talking about in Maine with healthcare providers is the use of the ICD-10 codes that speak to social determinants, quote unquote, diagnoses. And the use of that coding, I think, is our best initial shot at collecting standardized data that really can be aggregated and scaled and support strengthening analytics risk models around social determinant risk. Our largest and F2HC health systems are all looking at how to collect in standardized workflows and then document within the electronic record Z codes, and then from there aggregate that information. So you start to build aggregated data around those types of conditions. And I know payers are doing the same thing. I've been talking with some Medicaid departments that are really focused on Z code collection as well. But the other side of that coin is the assessment, and everyone's using a different assessment. And so I think we're kind of at the beginning of this, but I think we all have to do it. We all have to figure out how to do it. And there's different challenges with it. I think the biggest challenge is that most social determinants or community-based data is not standardized in a way that you can aggregate it and analyze it across a population in a standardized way, right? So, and also a lot of this data is collected in Excel files or very rudimentary databases or paper forms. So unless there's, scalable data collection processes, it's really hard to pull data together in a way that you can scale and analyze a population. So I think that's why we've chosen to approach it from a perspective of, well, what data and data structures exist today already that either can get aggregated at a statewide level, and also that other states could replicate, and so all the other states could learn from each other. And we participate in the Robert Wood Johnson Foundation DASH program, Data Across Sectors for Health, and this is our 3rd grant cycle with them. Robert Wood Johnson Foundation is also funding the Siren Gravity Project. So there's lots of work going on in this space, but I will take a breath and pause there because I know other folks have other things to say.
Thank you. Thank you. That's very interesting indeed. So Mike, what's been your experience at Delaware in terms of the social determinants and possibly the behavioral data?
I don't have too much more to add than what Katie has already said. We've had some similarities there. I'll say the one thing from a technology perspective, we are actually in the middle of going through a software change right now. We're actually going to be offering a new CHR product, but our previous technology vendor did not allow for the granular consent capabilities that are required for real robust behavioral data exchange. So it's something that we absolutely realize is important every single year and every single day, just about, you just hear and really gain better understanding of the value of paying attention to behavioral health. And so it's on our radar. When we roll out the new CHR, this is something that we'll be able to button up a little bit more.
Fantastic. So from Maine's perspective, a lot about social determinants and standardization, and from Delaware's perspective, a lot about behavioral health and consent. So Joe, from a payer perspective, what are your thoughts on social determinants data, behavioral health data? What's your experience, if any?
So I'll share a little anecdote. One of the biggest users in our market is a community mental health center, and they're not coming to the platform for behavioral data. They're coming because they don't have a comprehensive medical record, right? So they're picking up physical health data that they don't have, that better helps them understand how to work with their patient. And I think that was eye-opening for us. We just hadn't really thought it through. So that, I think that's, maybe an insight that maybe will surprise a few people. On the social determinants side, like the others, yes, we're investing time, we're investing energy there. I think as an industry, we have so much to learn. There's clearly so much opportunity to improve outcomes, right? I mean, there are things that we've changed over the last 20 years which are remarkable, but there's so much variation in outcomes, in treatment, in patient response, that we know that we can do better. And it would seem that, the next frontier is changing either consumer behavior or consumer environment, right? The things that are driving them to be compliant with therapy, to pursue access to the health system when necessary, et cetera. And so there's the evidence in terms of our ability to do that successfully is not there yet, but I think we're all really excited about the prospect of really chasing it.
I think so too. Let's see if we can squeeze in one more quick question, and just to cover it, because it may come from the audience as well, but are we having any issues, any downsides to aggregating so much data? And perhaps with Mike, perhaps start with you, where you were talking about consent. So any of those kind of consent privacy issues hitting you in terms of your ability to bring together all of these different data types?
So for us, the major issue is going to be reworking our data use agreements with our data centers. So as I indicated earlier, we have been live for 12 years. And so our data use agreements, when we first established things many years ago, was specifically for treatment, payment, and operations. Now that value-based care has come around, and now that analysis and research and actually putting the content of the data to work now, as opposed to just exchanging it, but actually, examining and analyzing the content of the information. That's probably going to be, the biggest thing that we're going to be working on in order to make, this information really, really useful. And the same thing is going to have to go with TEFCA as well, is that, when ultimately that gets straightened out and the final version is settled and the ink is dry, then we'll want to, align all of our data use agreements to be consistent with that.
Absolutely. So Katie, just briefly, your thoughts?
I'm sorry, could you please repeat?
The question is, do you see any downside perhaps to aggregating so much data? We all see the upsides, and there's a lot of exciting initiatives possible. Just briefly, do you feel you have the data use agreements under control when it comes to behavioral data and social data? Do you see challenges coming up? Or is it all moving ahead fairly nicely?
Yeah, I guess I would say two things. I think TEFCA and what happens with TEFCA and how TEFCA will or won't be implemented, and I think there's just a lot up in the air about TEFCA, but I think that will, one of the takeaways for HIEs, I think, in that space is that there's going to be a lot of data sharing agreement updates if it does come to pass, and in whatever those final versions look like. So there's a lot kind of unknown in that space that people are anticipating. Right now, Health InfoNet does accept protected state licensed mental health data into our exchange via a patient opt-in consent model, and that has gone really well. We've been doing that since 2015, so we feel really good about that. And we are now in a planning process for how to implement the SAMHSA regulation that went into really effect at the end of 2017, but wasn't really kind of published and shared until the beginning of 2018. And so we're right now planning an approach and a strategy for the healthcare providers in Maine to engage patients in opting in substance use treatment data. And I think the social determinants data that doesn't come from covered entities is going to be a big question, because you need consent to release that. And so that has been one of the things we've run into. So if you're a community-based CAP agency, a community action program, and you have Head Start information, you need permission per person to release that information. And that's where you're going to run into, I think, some challenges. Again, going back to, that's kind of why looking at larger data sets and larger scalable consent mechanisms is probably the better way to aggregate that data, but we see solutions for all levels.
Okay, and lastly, Joe, just briefly, because we want to take some audience questions, but did you have any other comments on the kind of consent and privacy and data use agreements?
I think our challenge is putting the data in the care path. So we're a pretty dense state, 8 million people, and 4,000 primary care physicians, over 20,000 independent physician practices, and so it's great having a lot of data. The challenge is, can we put some of this information in the treatment or the care path in a way that makes it easily used by the treating care team?
Right. Makes sense. Well, look, thank you so much for a fantastic discussion. I found that really illuminating. I'd like to turn it back to Claudia, who will take the audience questions.
Sure. Good afternoon, everyone. Well, we've got several questions, and if we're not able to answer all of them, we will try to get back with you after the webinar is completed. I'm going to start off with a behavioral health question, and it's not directed to anyone, but I think perhaps we'll direct it to Katie. Katie, I noticed that you specifically do a lot of behavioral health exchange, and this question is, how do you approach behavioral health information? There's so many concerns with exchange and getting consent and privacy and security. So, Katie, could you please respond?
Sure. So in brief, we do not accept any substance use disorder treatment information that's protected under Part 2 today. We just don't accept anything for that. We're just not set up to manage the consent and re-release of that today. We do accept what in Maine state law is defined as protected mental health information, and that's really based on the provider's licensure and program licensure with the state. And a patient can choose to opt in. It's an all or nothing opt-in. And what that means is that at just a given point in time, the person says, yes, I want my protected mental health data to go to be accessible in the exchange portal by any of my treating providers that can look up my record, my longitudinal health record in the HIE portal. So it's kind of an all or nothing one-time consent. It can be revoked at any point in time. Upon revocation, that data would be shielded in the exchange, because under state law it's required to be viewable in what's considered and defined as an emergency. A provider could break the glass and view that information in a one-time data viewing session. So that's really where we're at. We audit all of that activity along with all of the other exchange activity. We audit everything, but it's gone really well, and our focus has been to have our healthcare providers working with patients who have severe mental illness, and we're really focused on that population being educated about their choice to opt in. So those are the communities that we are working with to provide that education to the community.
That is really interesting. And Mike, at Delaware, do you use a similar approach?
Yes, we do. Yeah, not a whole lot to add there.
Well, I know it's a complex situation, and several HIEs are still sort of grappling with this exchange and really trying to use this to attack the opioid crisis. Going on to the next question, please comment. It's not directed to anybody, so Mike, why don't you respond to this one? It's please comment on integration with PDMP, use of blockchain, and direct access by patients.
So for PDMP, there is a state-run portal. And so what we offer right now is that within our community health record, we simply offer a link within our community health record environment to that portal. And then from there, the provider or the staff member can look at the information and get all the information that they need there. So that's something that we've had in our environment, I would say, for about 7 or 8 years at this point in time. On the personal health record front, we actually have a personal health record service where people can go in and look at all the that information. We've actually been looking to promote this, and we've done this with the help of some ONC grants over the years. And really, the lessons learned that we found so far is that when you try to do it at a consumer level, on a one-on-one level, as opposed to a business-to-business type of environment, and when you try to do it at a consumer level, we're just not seeing a whole lot of uptake right now. We even had a local broadcast and commercial during the Super Bowl a year and a half ago. We've had billboards. We've done everything that we can to promote this, and just on a one-to-one basis, it's just not working. And so our next foray is really to start working with employers and other larger scale entities to see if we can get the uptake. So I think for those of us who work in healthcare, I think we may have a bias towards wanting to get this information. But from what we see, the average consumer in the U.S., with all the information that they've seen out there, my point of view is I still don't think that they are quite ready to manage their own information. If for nothing else, I'm not 100% sure that they know what to do with it. And so we're just not quite seeing the response that we had hoped for.
Katie, any response to that?
No, I don't have anything else to add. I'm sorry.
Okay, no, that's fine. I'm going to throw a question now to Joe. How do you validate the data coming from the clinical systems for quality measures?
So I guess there's two parts to your question. One is how do we, how can we measure the data quality coming from what we call our provider partners? And we really can't, right? That we're not in a strong position. We have actually a pretty good understanding of our own data quality, but since we don't have access to source system, we're not really in a position to test that. From a quality measure standpoint, moving into next year, we think we're going to be able to use a number of data elements coming from the EMRs in a CCDA to meet CMS, STARS, and HIEs requirements, and it will also assist with risk adjustment measurement.
While you're still in responding mode, I'm going to ask you one more. How are you able to get health plans interested in receiving additional SDOH information from physicians?
Well, I can only speak for one, and maybe collectively for the Blues. And I think everybody is focused on SDOH. What we don't fully understand yet is what is the impact of focusing on one or another opportunity, right? We're referring to as care needs, maybe not a care gap, but a care need. So there's different probabilities of outcome for pursuing different needs, right? And there's different probabilities of patient response. And so at this point, I don't think anybody has good answers. But I think what we will see is some industry sharing, where people are sharing their experiences, they're publishing results, and so we'll kind of move in a particular direction. A lot of what we need is not confidential, right? That we can get certain types of socially determined information from the public record, right? From consumer data that we can buy from the consumer data companies, from the census data set. And as a payer, one of the biggest opportunities for us is we know maybe one of the primary social determinant drivers, which is family, right? So we understand family size, family composition, and oftentimes events, health events that are happening within the family, but also lifetime events, birthdays, graduations, deaths, right? And that can impact health or response to other health variables. And so I think you're going to see a lot of energy and focus from the payers, but it'll be in different places. Since there's not a lot of good data on where you should put your energy, I think different plans are going to put their energy in different places.
You mentioned that you can get this data from many sources and some public sources. Why do you think there is a lot of attention now on some of the concerns about using social determinants of health data?
I think there's sensitivity always around any time that we're venturing into an understanding of people that they didn't share themselves. But in today's marketing world, that's happening every day, right? So the minute someone walks through the door of the supermarket, the assumptions are being made about that consumer. People's prior purchasing history allows marketing organizations to make assumptions and to modify their marketing approach to those consumers. So why wouldn't we do the same thing to modify and essentially, what's the right word here, become more precise in the type of intervention that we want to try to deliver to an individual, right? What we want is and I'm going to say clinical, but clinical may be the wrong word here because sometimes it'll be social, but we want the intervention that will assist that individual in achieving the best health outcome for whatever the clinical issue or the care need it is that we're trying to address.
Thank you. Also, give this one to Mike. How does FHIR and Da Vinci resources fit into payer interoperability strategy? And also, Joe, if you could also respond to this, Mike from the HIE perspective and Joe from the payer perspective.
This one I'm going to have to politely pass. I'm not the CIO of DIN, so this one just is not my bailiwick. So I'll let Joe handle this one.
Okay, Joe.
Thank you, Mike. So, so I'm sorry, but I'm going to need you to Claudia, if you could be a little more specific in terms of how you're looking for me to respond.
Yes, I mean, this is just, I'm just reading this particular question, and I guess it's maybe the use of FHIR and Da Vinci and how it's being used, how you as a payer are using these resources. I'm sure for exchange of patient data and ability to add on privacy and security concerns or modes.
So two pieces. We have a FHIR-enabled platform. At this point, we don't have any partners who are prepared to do FHIR transactions with us. We have one who has committed to do it, but are not yet ready. And we continue to pursue that conversation with a number of large provider systems in the state. And my gut is the market's moving in that direction, but we're not ready yet, I think, as an industry. And then on the privacy and security side, I'm going to show my bias here, but I think the payers feel much more at risk from a breach, right? Than the providers do. And I think part of the reason is if a hospital system has a breach, right, the patients in their community are still going to go to that hospital, right? That is their hospital. That's where they're gonna go to seek care. If a payer has a breach, employers are going to find a different payer. They're not going to put up with a payer who cannot do a good job protecting data. So we're investing a lot of money in security, and we focus a lot on privacy issues. Again, because we feel from our biggest clients are large employers, and it's an expectation they bring to the game. Anytime we respond to an RFP, we are detailing our privacy and security policies, procedures, technology, protocols.
Thank you, Joe. With time, we're actually out of time, but maybe we'll just squeeze in one more question to Katie. And the question is: some organization leaders feel that Epic everywhere meets HIE needs. How are you handling this? Katie, do you want to take it, or should we, Mike, any thoughts?
Sure, I'd be happy to explain what's happened in Delaware. So we actually had one of our significant health systems in Delaware that was using Epic, and frankly, we ran into the same challenges. What the hospital or the health system ultimately learned was that Epic does not have 100% hospital and provider penetration. And so as a result, not all of that patient's information is available within the Epic system. And so at first, they didn't quite get that. But as we started showing them specific examples of all the information that came from all the other EMR systems, both ambulatory and hospital-based, about their patients, that wasn't available within Epic. That helped us, to solve the completeness issue. But then on top of that, once they started understanding, all the different services that we offer, things like the event notification service system, the alerting system, and all the tools and all the information that we can provide and feed into their care management systems, then they really, stood up and paid attention, to that. And HIE is much more than just about accessing information. It's receiving timely information, and at the point of care, and ultimately, utilizing that information for real effective care management.
Thanks, Mike. And I know we're out of time, but I was just wondering, Mike, while you're still with an open mic, what your thoughts are. You were probably part of the survey that we did in 2005 when sustainability was the primary concern. Why do you think there's such a shift? I mean, the shift is fascinating and great news, but what are your thoughts on the shift?
So my thoughts is that, I'll make a real quick story if I could. My son plays lacrosse, and I signed him up, to play for a team. And my wife said, I really don't know if we want to, if we want to make this our priority. I don't know if we want to spend all this money for them. Ironically, I had to go to an all-payer claims database conference, and so she ended up going to take my son to practice. And I asked her how the practice went, and she goes, "We have to keep our son on this team. This is great stuff." The same kind of thing is happening with payers, and I think with all of our customers. At first, they kind of heard everything in the background, and it didn't get really, front and center, to their attention. But now that all the payment reform is happening, all the value-based care is out there, and now that care management, is a significant, agenda item, on everyone's corporate objectives. I think people are now really understanding, the value that HIEs can provide. So I think that's what's really helping sustainability.
Very interesting. Well, really time is up, and I want to thank again Orion for the support of this webinar, and Joe, Katie, and Mike again for being such fabulous panelists. Very interesting conversation and information. And of course, Kaylee, who provided the information on the HIE survey results. So I wish you a good rest of your afternoon. Thanks again, everyone, and thank you all to the participants.
Thank you so much.